So without further ado, good morning from Tennessee. Morning, Chris. How are you? This is Vishal.
Good morning, and welcome to Kingsport, Tennessee, and Ballard Health, Holston Valley Medical Center. We're thrilled to be transmitting to New York Endovascular Symposium, so thank you, and thanks to PK and everybody there for another outstanding meeting venue. This may be my last day of live cases at this facility with a wonderful, wonderful team that I've grown to love and do love. So I want to introduce them before we start. They've dressed appropriately for the occasion here, I guess. Their mustaches have a lot less gray than mine. But to my right, Lauren Blevins-Omerovich has got the hardest job keeping the table under control here, and Chris under control here. Lauren. Behind us, we have the nursing talents of Michelle Tolliver. We have Courtney Cox, and great industry friends in Anna Jones with Abbott and Jordan Pleasant with Shockwave. And then running in the background there, we have Jessica Linkus, who's going to be doing all the runoffs. So any of the good runoffs and technical stuff that you're going to see belong to Jessica and the team. So just a phenomenal group of folks that I've been honored to work with for a long time. All right, we have a good case for you, I think. Let's go to our slides, please. All right, here are my disclosures. Next slide. This is a tremendously nice 64-year-old former policeman and an outdoorsman, and he has a long-standing diabetes, hypertension, dyslipidemia, a very strong family history. He is a non-smoker for life. He has a component of legal blindness from amyloid streaks, which I had not heard of before, and I learned something. But he has severe claudication, about 20 to 30 yards, left worse than right. And then working outside, injured his foot with a nail-penetrating injury. It really healed slowly on the great toe, ultimately healed with good wound care. ABIs had medial calcinosis, but you can see them there when they finally could get some, and then they dropped significantly with exercise, with low digit pressures, and monophasic distal signals. He had a CT angiogram, which they've done some changes in our security, and I couldn't break through that Fort Knox, so I'll just tell you it's very dense calcium and CTO of the tibioperoneal trunk, subtotal in the anterior tibial, and SFA. And he has ongoing severe symptoms despite maximized medical therapy and a walking program. Next slide. So in summary, he's an active, just a phenomenally nice human being who's got multiple risk factors, heavily calcified fempop, tibial disease. By the way, you'll see his posterior tibial is obliteratively occluded, and he comes in with a component of rest pain claudication for us to fix. Next slide. So let's go to the floor and show you what we've done so far. Like all, I think on the panel, we use vascular ultrasound, allows you to get in a good spot, especially good for Darren and TVARs and such, and EVARs. Here is the big, nice vessels in the aorta-iliac system. By the way, he's 6'3", closing in on 300 pounds, so he's a very well-proportioned gentleman. Here is his SFA, and you can see that it's coming in. You can see the dense calcium subtotal occlusion there, and then below the knee, there's a subtotal occlusion, the anterior tibial and the TP trunk. Very, very delayed filling. Jessica was very patient, so thank you, Jessica. And you'll never see a ghost of the PT, which has been long gone obliteratively throughout its entire course. This is on a 5.5-second delay, and you can still see with a 5.5-second delay, it takes a while to get down to the TP trunk in the anterior tibial. And this is a little bit unusual, more RAO. That at least shows you that there are some microchannels there in the AT and the TP trunk. And this is the kind of an oblique of the SFA right there. And this is just a view of the calcium that gives you an idea, the calcium extent that we have there, even in a non-smoker. Let's show the IVUS images before we've done some IVUS. So let's start with the AT, please. We had to do a gentle balloon to facilitate passing of this, but you can see that it's dense 360-degree rim of calcium, very tight, not as big as I was hoping. We'll show you those measurements, and she told me you can't always get what you want. All right, next let's go to the TP trunk. Is this our TP trunk, Kanice? Okay, so here's a TP trunk and a similar story, not as big as I wanted it, and really pretty dense calcium right here. Next, we'll show you the SFA. This one I want to let run for a moment. Go ahead. This is starting down the pop where it didn't look so bad, but you'll see it'll come in and out here, and throughout this SFA is just going to be multiple areas of almost pinhole circumferential calcium, like there, and I mean, it's a redundant story. I won't bore you with the whole thing, but you can get an idea of the circumferential calcium. We are within the true lumen. There are multiple pinholes, and it's a pretty long lesion. Okay, next. And now here are the, I tried to be as generous as I could with the measurements, really wanting to get a 3.5 or 4.0 out of these tibials and could not do so. So this is in the AT, and then next to the TP trunk. Again, not as big as I would like distally, but it is what we've got. And then finally, Phil, let's go back to the fluoro. So we've wired each of these carefully. I'll get a sense from the panel in a moment what kind of wires you would go with to get those. And that's where we are right now. So long introduction, but let's please hear from the panel briefly. As we're going to get to work as we do this, because we've got a lot to get done in our 30 minutes together. And maybe if nothing else, we can come back for a brief run if we need to between lectures. I'll leave it up to your moderating capabilities, or excuse me, expertise. But what strategies are you going to want? Are we going to go tibial first and SFA, or SFA and then tibial? And what strategies are you thinking?
All right. Yeah. Thank you, Dr. Metzger, for a great presentation. Very interesting case. So yeah, it's a good question. We'll continue with what Dr. Metzger asked about to the panel. Let's start with Sahil. Sahil, what do you think?
Well, I think if I were to predict, probably going to deal with the tibials first, secure a victory there. I think the SFA, knowing Chris, there will be numerous options, but supera scaffolds are likely to be deployed there with some drug-eluting technology as a supplement. But I think securing the tibials in this specific case is really important. You have to have great outflow if you're going to scaffold the SFA. And that's what I suspect we'll do first. There's a number of ways to attack it. I suspect he'll use some sort of calcium ablative technique. And he's leading the witness by advancing the catheter as we speak. Yeah, right. And subsequently, we don't have any great drug-eluting technology for the below knee segment yet, but we're hoping to in the not too distant future. So I think get a good balloon angioplasty result, get a good outflow, and then work on the SFA.
Right. Anybody else with a different strategy?
The one thing I would say, a couple things, is there's some advantage to the fact that the SFA is open, so you can visualize reasonably well the distal tibial vessels. In the case where there's a long or difficult total occlusion and the visualization is poor, I will sometimes do the SFA first, at least open it, so that I can better understand what's going on in the tibials. That's not the case here. The second point I wanted to make was that the IVUS at the SFA was very useful because it really gives us an idea of what's going on with the calcium. It's not as much of the nodular calcium as I suspected from the angiogram. It is more circumferential and surface-based, so I'm a little more optimistic that IVL will be more successful. Some of the nodular stuff is not as easily treated with IVL, so I'm hopeful, based on the IVUS, which I think was very useful, that that'll be a good therapy.
So, I mean, let me ask the panel, I mean, especially for people out here in practice, how many of, or what percentage of your cases are IVUS involved in decision making? I mean, I know it's a live case, we want to be academically and get all the information as possible, but in real world practice, in your practice, what percentage of your practice involves the use of IVUS?
Increasingly more. I think we did not before, but like now we're fine. I completely agree. The IVUS changed everything. Initially, when I saw the angio for this image, I thought probably no stent. You're not going to get good stent apposition because it looks like there's nodularity. I definitely thought you had to treat above before below because there's a high chance you can knock something off and you can address everything at the same time. But that IVUS showed it's actually looked a lot better. Very rarely does IVUS look so much better than an angio, but I think this is like one of those cases it did. And it helps you with everything, especially in a very calcified vessel. Sizing, I think, is extremely important in a very calcified vessel, especially more so, and this helped a lot. So a lot more now.
All right.
I was extremely helpful, and I agree with the approach of treating tibial vessels first. If you have a great result there and you're satisfied with what you've got, then I would put a filter down in the distal pop and do atherectomy of the SFA, and then see what kind of drug eluting technology to use. Most likely ending just stenting that with drug-eluting stent.
Yeah, I think that was the point I was going to bring up, is how many of you will use a filter? You could use smaller size filter what if you use a smaller size filter in the AT and do all the intervention rather than trying to exchange and try to rewire with a filter down the SFA? Would anybody take that as a strategy?
I think you need pretty large filter there, because I would expect a lot of debris from, it's quite a long and calcified
Right.
segment in the SFA. So I think the size of the filter matters. And as I said, I will just treat tibials first, make sure I'm happy with the result, and then put a big filter in the distal popliteal, so so I could safely work on my SFA.
Yeah. All right. So I guess by the time Dr. Metzger does I think he's doing some shockwave in the tibials, we'll start with the lectures and then we'll come to the back to the case again. All right. So I think we're back in business. Dr. Metzger, can you hear us?
I can. I'm sorry we left you for a little bit.
Right.
Let me take a picture here, and I'm going to go. I'll bring you right back to where we were. Good one. Go to 7.
Chris, could you comment on the sheath size that you used to do the dual wire, dual balloon, all the kind of work that
Yeah,
you've been
so
doing
we've
here?
got a 7 French
Right.
bill. I use a 7 for everybody, and usually I thought about an 8, and I probably should have. You saw his aortic vessels were so big.
Yep.
We're going to need a Dorado for that.
You're using a little
So we used
homegrown-
a 7.
Are you using
Yeah,
a little
so let me
homegrown
go-
spring here?
Absolutely. It is a combination. We call it a Metzger shock, and it's an interesting name that we've coined here, but it's kind of a combination of shockwave lithotripsy, angioplasty, and an extra wire. So let me take you back to where we left off here. Here was our lithotripsy. By the way, we used a 3.0 lithotripsy balloon, even though it was 2.7 or 2.8 in the anterior tibial. Okay, and here's the result we got after that. Okay, and it actually looks very good. I don't see any dissection.
Yep.
And so we are prepared to do DCB or DES if needed, but didn't think we needed it at this point. Now we went over to the TP trunk. You can see there was a little bit of a waste there. Again, we went a little bit aggressive compared to the distal measurement. We used a 3.5 because I think the comments were very correct that you really need at least 1-to-1 sizing. So here's a couple inflations with a 3.5 balloon. Here we'll come back and later get the panel discussion. I think it looks very good. There's a potential for a little bit of a dissection here, but it's for sure non-flow limiting. I think we'll save and see how that looks later. And then now we went to the SFA. Now, Anwar, you talked about distal protection. I love the NAV6 distal protection in complex disease. I believe that because we opened 2 vessel runoff to the foot and we're using lithotripsy, that there's less of a need for that, certainly than with other atherectomy devices. So this is a 7x60 shockwave balloon in the SFA. And you can see on that last one, we've got a little bit of a waste here. So we're going to adjust our emitters on this one. And if we don't get that, Sahil had mentioned interwoven stents, and he knows me pretty well. So there's a pretty good chance that may come to fruition. There, go up, please. But if that's the case, we want to make absolutely sure that we get complete expansion. You have one. Go to 8.
Yeah, I think that's a great point. I mean, especially talking about distal embolization, where shockwave is essentially increasing the elasticity of the vessel, but you're not actually debulking by doing directional, rotational, or orbital, or any of those atherectomy devices. But would anybody on the panel add some? If you think it doesn't expand well with shockwave like you see there, would you add some other atherectomy over it to get a better luminal gain before you start doing your Supera or DES or any regular stents?
I personally would not. You start making it a really expensive case. I think that these lesions where you see this heavy, bulky, eccentric calcium, which you're seeing here, even though the thought was it didn't look that bad on IVUS, it is bad.
Right.
And that this is a lesion that probably needs scaffolding. So I totally agree with the vessel prep and aggressive dilation with shockwave. You're going to need that to get your supera properly deployed in this lesion, but I would not add atherectomy on top of it.
All right. Okay.
And I agree with Darren. Darren, it's always good to hear your voice too, especially when you agree with me. I like that even more, buddy.
Chris, I do have to poke you a little bit if we're going to talk about
Yeah.
level 1 evidence. What kind of saphenous vein did this guy have?
Oh, that level 1 crap.
64 and a normal
Yeah, whatever.
function?
So here's how I mapped it. I mapped and said, no, it's not so good. He
Awesome. All right. Till the time you get the, go ahead, Dr. Metzger. You had a comment.
Setting up
But
for
in all
tomorrow.
but in all fairness, he did say he's 6 feet, 300 pounds.
That's
And,
fair.
no,
so-
that's 6'3". But who's
6'3".
counting?
Six.
And listen, when he's that big and he tells me what he wants, I listen.
It's like the Tennessee standard. All right. So we're going to quickly move. By the time he does the shockwave of the SFA, we're going to move on to our next talk. All right. So we can see that Dr. Metzger is, even though he was using his technique, is having some mid-SFA lesion, which he's trying to expand. So Chris, do you want to comment on that?
So what we've done, as I said, live case or not, we're going to do it the right way. So we went up with a 7 Dorado. It ruptured. So we're doing an 8 Dorado, and then we're going to take a look with y'all and decide what we're going to do with the SFA. Come on down. So this is an 8x20 Dorado.
And what size shockwave did you use, a 6 or a 7-0?
I'm sorry, say again?
What size shockwave did you use in your SFA?
Yeah, got you. It was a 7x60 shockwave. Take it out of her both. And so we went up pretty aggressively with that. And I'll go back and show you the pictures because we've been back and forth a little bit. And then just show you where it didn't completely expand. We can do that quickly. I'm going to separate our wires here so that the anterior tibial, we'll take pictures of the tibial. I'll get to panel's opinion. And what I think we'll do is then treat the SFA, leaving the wire in one vessel, the one that we think is most likely to need a repeat IVUS and or a scaffold. Take the other wire out. So that I don't stent it in place with long interwoven stents and go from there. So let's take, I'll quickly get ready for a picture here. Again, I'll take you back through this. This is just our Dorados, and that's after we had a couple areas like that didn't completely expand. Most of them did. Everywhere else expanded pretty nicely. Down here, that all expanded nicely. So let's take a tibial picture for everybody first, and then we'll make sure I know which wire is which. Because they look similar. All right, ready? All right, go ahead, inject. Notice how much quicker is down there now?
Yep.
And I got to say, I think we're looking pretty good there. I think we go on with the SFA.
I agree.
Go ahead. Let me just identify which of the wires is which. The only way I know to do that now is to wiggle it. It's called a Tennessee wiggle. So that's a perineal wiggle, I think. Let me just make sure. I lied. All right. So this is the anterior tibial. Oops. That's a perineal wiggle, sorry.
The wrong wiggle.
No, I wiggled in the wrong direction. She's a better wiggler by far. We all know that. All right. So let's take our 6'5". So the vessel was about 6'3". I'm going to get a little greedy. I hope I don't regret it. But we're going to try to go for a 6'5" interwoven stent because I really found Darren and Bill and some of the others, Zahil, that are very familiar with this. I really believe that if you can get it well expanded, the bigger the diameter of these, the patency of these long term is very, very, very good. Any thoughts on that?
Yeah. Anybody in the panel?
Totally agree, Chris. I agree with this strategy, and I think it's the right approach. I mean, the other utility of IVUS is to make sure that you're accurately sizing as well. So I don't remember what you measured in the SFA with IVUS.
It was 6'3".
Yeah.
In some areas 6'5", so we're going to go with the bigger of the two. Notice, though, that lithotripsy did a pretty darn good job. Other people that leave nothing behind could start arguing, go ahead and hold the wire, that we could leave nothing behind and just do DCB with a 6 or 7 DCB. I got to say, I think with this degree of calcium, I'd rather put scaffold, especially when the scaffold is the right scaffold. And I believe that the interwoven stent is the right scaffold here. So what we're going to do is, if you'll show my hand maybe here instead of my face, it's much better look at the hands. And then in just a moment, have you hit view roadmap, please? Hit view roadmap, please.
So anybody
All
will,
I'm going to do is
go ahead.
go ahead.
So, but anybody would have a different strategy, like in this case, maybe put DCB and take another picture, or maybe DCB picture IVUS, and then decide on the stenting, or you're just going to go upfront stent? I know Dr. Metzger has chosen this stent, but anybody would have an other alternative strategy on the panel?
No, I think it's controversial about whether or not a drug improves the outcome of Supera. Supera is sort of a unique scaffold in that sense that it doesn't seem to improve that much. On the other hand, it doesn't hurt necessarily to use a DCB before you put the scaffold in. I think, as you can see, just by the behavior of how the scaffold's going in, even in the hands of an expert operator, this artery is chock full of calcium. And it almost certainly would look like there's a bomb that went off inside if you did an IVUS.
Right.
And a scaffold is going to make the runoff substantially better.
Dr. Gray, Dr. Schneider?
Yeah, I would agree.
7 by 20,
I generally use DCB before any stent
yeah,
I
sure.
put in, any bare metal stent, for all the reasons that he listed. But the other thing is that I think if you had done an EVIS here, you'd probably see some flow acceleration, Doppler accelerations, and I think again, IVUS would probably show some areas of under expansion.
Right.
So I think we don't really account for that as much as we probably should, and I do think it lends to patency issues long term. So that's all speculative, but I think
So,
for that reason I like the idea of putting a stent in.
right. But how about the concept of doing DCB and doing so-called spot stenting, only the areas that really need it? Do you believe in that, or is just stent all the way?
I'm not sure there's a big advantage to that at this point. For some of the lesions, like if it's a very clear dissection, inflow, outflow, cap, I like the tack for that. I think that's a great option. But when this is different, this is a long calcified, needs a scaffold.
I agree that if the vessel is not as heavily calcified as this is, that you can try a, a DCB strategy, and then IVUS and spot stent if you need it, if you have a serious area of recoil or dissection. But in this case, I mean, you can just see it's obvious with the calcium burden that's here.
Yeah.
That's not going to be a successful strategy. And I bet if Chris had put the IVUS down before the Supera, you would see that vessel looked horrible, and that there's really no alternative in my mind than scaffolding with a stent like Supera.
Right. So, Dr. Metzger, how are your hands doing? You feel tired? I think
I was just going to say real briefly, the tack is not an option here, I don't think, with the calcium
No.
and the size of the vessel.
No, I was only referencing dissection really as
Right.
potential.
Right, I got you, Bill.
Yeah.
Chris, this is looking like a really tough deployment.
Yeah.
You've put in more Superas than just about anybody on the planet, and it's obviously fighting you here.
It's fighting, and it's fighting because I got greedy with the 6.5. We could have, I should have. I got coached over here. Once you use a 6, you'd be a lot better. But it's okay. It will look good in
It'll
the
be
end.
fine when you
balloon
post
it up,
dilate.
yeah, that'd be great.
Yeah, I think you can see from the Supera deployment, like you said, the lesion is very significant. This is after shockwave. So even though the balloon had expanded the lesion well, the Supera itself has given us some...
So why don't we do this? Do you have another lecture
Yes.
to go to, and then I'll post-dilate this, and then put in the last Supera and come back with an IVUS?
Yes, that's what we're going to do. We're going to talk about post-dilating Supera as well, if it really works. But so, Dr. Metzger, we see that you're going to balloon your Superas. Is it okay if we do our final talk with Dr. Gray and then come back to you, or you want to say something before
Well,
that?
whatever you want to do. I've got the IVUS ready to go, but I can record that as well. So we've already put our other Supera and IVUS. We do a runoff. Why don't we show you the IVUS?
Sure.
And then while you go to Bill Gray, then come back and we'll do
Perfect.
the final runoff. It'll take us a minute. So let's do our
That sounds
IVUS,
good.
and I'll show you what we've done. Okay?
Yes, please.
So we post-dilated. I just want to show you this. This is, I know it was a little bit of a challenge, but there's no other stent that will stand up to that. We're going to show you that on IVUS. The next Supera behaved better, so healed more like we would be used to in Kingsport. And now we're going to show you the IVUS. So let's show the IVUS. And why don't you go IVUS and fluoro, please? All right, there we go. So that's where we are. So go ahead and record, please. So we're just distal to the stent. All right, now I want you to look at, as we get into this stent, this is the beauty of Superior. There are a couple little bit of errors, and we can hit those a little bit harder, but by and large, it's a perfect zero like that throughout and that's a 6.5. And so it really, really does what no other nitinol stent will do in the SFA. And again, I think you see the idea there, and I'll just pause for a second. But that's what it looks like through the vast majority of the stent. So why don't you go to Bill, and we'll do a runoff, and then we'll wrap it up, if that works for you guys.
Chris, you'll get good at this someday. Don't worry.
I'll do my best. They're coaching me here.
All right, thank you, Dr. Metzger. We'll be back. All right, so quick thank you, Dr. Metzger, for patiently waiting. Let's see what you have, and then we'll just wrap up for working lunch.
Well, it's been a fun ride together with my friends here. So let me just show you a final runoff. Here we go. Again, we started the stents right there. They look really good. That's the Foley on the other side, not Navy fistula. And we have nice runoff there. And I'll just show you a picture of the runoff. And these are the tibial vessels we worked on with lithotripsy angioplasty alone. And we ivostat. We don't have time to show you, but there's no dissection in there. It looks very good. The lumen looks good. So I think for right now, we're going to call it a day. His toe had already healed. I think this is going to help his claudication and a little bit of rest pain significantly. And I really appreciate the help of all the panel and our friends here. And again, we have a competition who's got the better mustache. It's not fair because mine's hidden, but I'll let you all vote in the audience. If you could put a poll up there, I appreciate it.
We'll get you the
thank
results.
my friends. All right. So thank you very, very much, and we'll look forward to seeing you in the next case.
Thank you, Dr. Metzger and his team.